hypomethylating agents really have been the de facto standard of care for older patients who are unfit for intensive chemo for some time, since they were approved for MBBS in the US in 2004 for azacitidine, 2006 for decitabine. They have effectively been used to treat patients with AML, although randomized trials that compared those agents basically to other options basically did not show improvement with the hypomethylating agents in terms of overall survival. However, they definitely lead to improvement in clinically meaningful outcomes such as transfusion independence, quality of life, blood counts, hospitalizations, things like that. And I think because of that and because of lack of other great options, hypomethylating agents have become the standard of care in those agents. However, the data supporting their approval basically, as I mentioned, did not support a survival advantage in a definitive fashion. And the two agents were not directly compared to each other. We presented one analysis basically from the Astral phase 3 trial in which we compared azacitidine and decitabine. And we also presented in the last American Society of Hematology meeting a large data set from Medicare SEER database in the US in which I think a couple of thousand patients were compared who received either azacitidine or decitabine or azacitidine. And the conclusion from both of those analyses, which are probably the largest that have been done to date in the use of hypomethylating agents for older patients with AML, is that they don't seem to be different. There is a lot of talk, and we get that question often from community physicians: should I use decitabine or azacitidine? Our conclusion is that both agents don't seem to differ in their activity once you adjust for confounders. And the median survival with both is in the range of 7 to 8 months. So clearly, while they are helpful, there is a lot that needs to be done. We actually also have published data suggesting that in the US, there is a significant underuse of hypomethylating agents. As many as 40% of AML patients in the US in the year up to 2013 were not receiving active therapy. So many patients are not being treated, and I think partly because those hypomethylating agents are not perceived to be very active, and because they have to be given by injection and the patient has to come frequently. So I think the next step that moved from the use of those agents was to try to study oral hypomethylating agents, which now are quite advanced in their clinical evaluation, as well as combination-based approaches.